Good evening, everyone. Good evening, good morning, Shadi sir. I think today's topic is again amyloidosis. I think nowadays we wanted to discuss more on amyloidosis. It's a rare case. I think how it's very difficult to manage amyloidosis. The diagnosis is difficult as well as management also is very difficult. But today this Lakshmi Maithili is there. So she's a hematologist. Now she's practicing in Vizag, Apollo Center. So she's going to discuss this article on DARA-based chemotherapy in amyloidosis, especially this stage 3 Mayo. Initially this Mayo stage 3B was excluded in regular clinical trials. So in this, I think she's going to discuss this data. After this presentation, we'll have the discussion. Over to you, Maithili, Dr. Maithili.
Thank you so much, sir, for giving me this opportunity. Really very glad to have been presenting this article. So, shall I share my screen, sir?
Yes, please, ma'am. Yes, please.
So, very good evening, everybody. So, as a part of Journal Club presentation today, I'm going to present this article. It was published in Hematologica Journal in Jan 2024. Daratumumab in first-line treatment of patients with light chain amyloidosis and Mayo stage 3B improves treatment response and overall survival. This was a retrospective multi-center study conducted in Germany and Austria. And we know treatment of patients with stage 3B amyloidosis, AL amyloidosis, is very challenging and the prognosis remains very poor. And stage 3B patients were excluded from the pivotal trial, that's the Andromeda trial, which led to the approval of daratumumab in the frontline treatment in amyloidosis patients. There was a post hoc analysis in the Andromeda study that showed that patients with cardiac involvement up to stage 3A were the ones who benefited most from addition of daratumumab in standard chemotherapy. Daratumumab, we know it's a IgG kappa monoclonal anti-CD38 antibody approved in 2021. The mechanism of action is very specific. It has less cardiotoxicity it has less effect on the cardiac myocytes, hence less cardiotoxicity. So favoring its use in advanced cardiac disease. So Kimmich et al. Had published in Blood 2020 their study in relapsed AL amyloidosis patients with NT-proBNP more than 8,500 picogram per ml. And they have seen that median overall survival was 6 months in those treated with DARA plus DEXA and 11 months in those treated with DARA, bortezomib, and dexamethasone. And Rajshekhar Chakrabarty et al. Had published their study in 19 patients of stage 3B amyloidosis, which has shown a promising efficacy and safety profile with a 12-month overall survival of as high as 67.5%. Theodora Kaku et al. Greece study had published in 22 patients who were treated with daratumumab-based regimens with a very good hematological response rate as good as 64% VGPR or better at 3 months. So overall, these findings suggest that daratumumab-containing regimens may also be an effective and tolerable treatment option for patients with Mayo stage 3B in the first-line setting, potentially representing a step forward in the treatment of these group of patients. So coming to this study, it was a retrospective study, enrolled 119 consecutive patients with histological diagnosed AL amyloidosis and Mayo stage 3B. These patients who presented between 2016 to 2022 at 4 different sites across Germany and Austria, Heidelberg, Essen, Vienna, and Würzburg universities. And they had investigated the efficacy of addition of daratumumab to the first-line therapy in AL amyloidosis and Mayo stage 3B patients as compared to bortezomib-containing regimens and other less commonly used therapies. So this was the study design. This was a study where it was a retrospective study. They had enrolled 119 patients. Out of them, around 21 were excluded because of early deaths, pre-treated multiple myeloma, and concomitant lymphoma. So the remaining 98 patients, out of the 98 patients, daratumumab, 98 patients, 27 patients received daratumumab. Most common was the Dara-D regimen. And further on, they were adding bortezomib later. And whereas in the bortezomib group, most commonly 63 patients received bortezomib, and out of them, 55% patients received bortezomib plus dexamethasone. And out of them, 7 patients, daratumumab was added later. And out of all these patients, 8 patients received other regimens like melphalan, dexamethasone, and bendamustine. The treatment decisions were left to the local physician's judgment without any cross-center coordination. So Mayo stage 3B, we know, is defined as NT-proBNP levels more than 8,500 picogram per ml and cardiac trop-T more than 0.035 nanogram per ml or HS trop-T more than 50 nanogram per liter. OS was calculated from the date of treatment initiation to death or loss of follow or the date of heart transplantation. Hematological responses were assessed at 2 months period and 6 months period, as recommended by the International Society of Amyloidosis. So coming to the results, in between the 4 cohorts, the baseline characteristics were almost similar. There were no much differences. It was seen that in Heidelberg and Würzburg group, mostly they were preferring bortezomib-based regimens as compared to SN and Vienna group, who preferred more of DARA-based treatment regimens. So when we divide it based on the group wise, daratumumab, bortezomib, and other regimens, almost all the baseline parameters were quite comparable. The other regimens, in the other regimens, the median age was slightly higher as compared to dara and bortezomib group. So the baseline characteristics were almost comparable in all the regimens. Just a recap of how the response criteria in amyloidosis. Hematological CR is defined as serum and immunofixation electrophoresis negative and normal free light chain assay. VGPR is reduction of DFLC less than 40 milligram per liter, and PR is defined as 50% reduction in DFLC. Coming to cardiac response rates, the cardiac response rates were based on the NT-proBNP values. Less than 400 picogram per ml was considered as complete cardiac response, and more than 60% reduction of NT-proBNP as compared to baseline is considered as VGPR. 31 to 60% reduction is PR. Less than 30% reduction of NT-proBNP is non-responsiveness. And progression is either increase in the NT-proBNP values more than 30% from baseline, or trop-T progression more than 33% increase, or decrease in ejection fraction of more than 10%. So based on these response criteria, these 3 groups were evaluated. And the 2 months hematological response, was assessed at 2 months and 6 months. At 2 months, the overall response rate in the DARA group was as high as 59%, as compared to bortezomib 36.7%, and other treatments, the overall response rate was 28.5%. CR rates were comparatively very high in DARA group with 36.3% CR as compared to bortezomib 4% CR, which was clinically statistically significant. Coming to the VGPR, in DARA group it was 4.5%, 18.3% in the bortezomib group, and others for 14.2%. Partial response was 18.1%, 14.2%, and 14.2% respectively. So here we can see that in the DARA group, the overall response rate was 59% as compared to bortezomib 36%. However, the CR rates were very statistically significant in the DARA group. This was the hematological response at 2 months. Coming to the 6 months hematological response rate, overall response rate in the DARA group was 66.7% as compared to bortezomib group 40.7%, and others was 25%. CR rates were 36.3% as compared to 4% in bortezomib group and 12.5% in others. So these two, the overall response rate and CR complete responses were statistically significant as compared to in the DARA group as compared to the bortezomib group. VGPR was 16.7% in both the groups and 12.5% in the other group. Partial response was 8.3 and 9.3 respectively. So Kaplan-Meier landmark analysis for overall survival regarding hematological response at 2 and 6 months. So the 12 months overall survival in patients who had achieved CR was 90%. As compared to patients who achieved VGPR, it was 82%, and patients achieving PR was 80%. And patients who have achieved no response, the overall 12-month overall survival was as low as 17.4%. And this achieving at least a partial response was seen to be statistically significant as compared to achieving no response at all at 2 months. At 6 months, the overall response rate, coming to the 6 months analysis, the patients who have achieved CR, the 12 months overall survival rate was 94%. Patients who achieved VGPR, it was 79%, and PR was 86%, while all the non-responders who were alive at 6 months after the treatment initiation died before the completing the first year of treatment. So, this graphs, we can see that achieving at least a PR is clinically very significant because it improves the overall survival rates and statistically significant. Coming to the Kaplan-Meier analysis showing survival rate according to first line of treatment, in the DARA group, the 6 months overall survival was 70%, whereas in the bortezomib group, it was 51% and 25% in the other group. The median overall survival in bortezomib group was 6.6 months. The group who received other regimens, it was 2.2 months, whereas median survival, overall survival was not reached in daratumumab group. So there was a statistically significant difference between DARA and bortezomib group when we see the 6 months overall survival and median overall survival. Coming to the cardiac responses at 6 months interval, the overall response rate in daratumumab group was 45.8%, and bortezomib group, it was 21.4%, which was statistically significant. VGPR rates were 25 and 14.3%. The 12 months overall survival in patients who had achieved a cardiac VGPR or a cardiac PR, the 12 months overall survival was 100%. As compared to in cardiac responders, non-responders, the overall 12 months overall survival was 73%. Coming to the baseline characteristics, whether they predicted the overall response, a univariate Cox regression analysis to predict the prognostic factors, none of them were statistically significant. Baseline factors were not very significant. And the forest plot subgroup analysis, it was seen that almost all the factors favored the daratumumab arm. Statistically significant factors were DFLC more than 180 milligram per liter, and higher levels of pro-BNP also favored daratumumab arm. And GFR more than 30 ml per minute also had a significantly favored daratumumab arm. As the NT-proBNP values were increasing, we can see that it was more favoring the daratumumab arm. Whereas higher than 30,000, there was no much statistically significant difference between the DARA and bortezomib arm. So the benefit of adding daratumumab to first-line therapy appeared to increase relatively with increasing NT-proBNP up to 25,000 picogram per ml. So patients in the daratumumab arm had significantly better outcomes. Median OS was not reached after 14.5 months median overall median follow-up, as compared to bortezomib, which was 6.6, and other regimens, it was 2.2 months. While the 6-month and 12-month overall survival remained same at 70% in the DARA group, OS was found to be decreased from 51% at 6 months to 41% at 12 months in bortezomib group. There was we can see a significant overall survival advantage for patients who survived second, 2 and 6 months and achieved at least a PR as compared to patients who had no response. Some limitations of the study was it was a retrospective design and unavailability of few clinical parameters or response data in some patients. And therapy-associated side effects were not recorded in these, as it was a retrospective study. So concluding, this study demonstrates for the first time the superiority of an upfront treatment with daratumumab over current standard of care with bortezomib in Mayo Stage 3B patients. The better survival rates in the group treated with DARA suggests its efficacy and safety profile in this vulnerable group of population. Further randomized trials should be conducted to confirm the data and to define the best sequence of daratumumab combination therapies. With this, I would like to conclude and thank you very much for this opportunity.
Thank you, Dr. Lakshmi Maithili's wonderful presentation, very crisp and clear presentation from your end. Yeah, now I think we can ask anyone ask some questions. They can type in the chat box also. So, sir, I think just one or two doubts from my end. I think this. So when do we consider for this autologous transplantation in a amyloidosis patient, sir? I think, do we have any something like a related contraindication? I think we have seen one or two sudden cardiac events during the transplantation. So sometimes we'll feel that I think better not to do the transplant. They can live longer without transplantation. Can we just risk stratify which patient should not go for, or we should be very cautious during this transplantation, sir?
So, the transplant, we know it's a very effective therapy, but the use has come down over the years, partly because, I think it's important to look at it as kind of three different phases in terms of how the treatment has evolved. Initially, when we used to take patients, we used to see a significant early mortality up to the 20+% in some of the studies in patients with light chain amyloidosis. Now, over time, I think we got a better sense of the patients who are at a high risk of early mortality, and this included particularly patients with with a significant cardiac involvement. So we had developed some cutoffs both for the NT-proBNP as well as the troponin in terms of patients whom we should not take to autologous stem cell transplant. The second group of patients are patients with multi-organ involvement. So if you have more than 2 organs involved, the risk of early mortality tends to become higher. Then there are patients with overall poor performance status, poor functional status. We typically don't end up taking them to transplant. Then even though they are not quite codified into the eligibility criteria that we commonly use for autologous stem cell transplant, patients with significant effusions often don't do well. Patients with low blood pressure don't do well usually, especially patients with a systolic blood pressure under 90 tend to, or under 100 tend to not do very well. And then even if those patients kind of meet the criteria for proceeding to transplant, if they have significant issues with fluid retention and hemodynamic issues at the time of stem cell collection, those patients also don't tend to do well. So even if you decided to go to a transplant and you run into all these problems with stem cell mobilization, it's a good idea probably not to do an autologous stem cell transplant. Now, the question is, it was a reasonable thing to consider when we had the regimens we were using before daratumumab came along, because it would give you a very rapid, after you give 2 or 3 cycles of induction therapy with a bortezomib-based regimen, a young fit patient, you do an autologous stem cell transplant, you get a high hematologic response rate and also high rates of organ response. So one of the distinct advantages of the autologous stem cell transplant in amyloidosis was the median time to next treatment for patients undergoing an autologous stem cell transplant was roughly about 6 years. And that is understandable because these are patients with small clones, not a very aggressive clone. And some of the subgroup analysis we had done in our own cohort suggests that people with more towards that myeloma end of the spectrum, especially those with more than 10% plasma cells, are those patients who tend to benefit even more so with transplant than the ones with kind of the other end of the spectrum. Now, so the durability of response was a clear advantage for the stem cell transplant. We don't really have a good sense of the durability with these new regimens, especially with DARA-based combinations, because the data is not mature enough at this point, even from the phase 3 trials, to give a very good sense of that. Now, the question is, why have we started doing less and less of autologous stem cell transplant? The main reason is when you think about the treatment approach for amyloid, there are two things that are important. One is obviously the depth of response. We really want to get the preferably get to a complete response in patients because that gives the maximum possibility of a organ response. And this is particularly true for patients with cardiac disease. The second is the kinetics of response. We want to get to that response very fast if possible, because the sooner we get the response, the quicker the organs are going to start improving, because it's almost a kind of competing risks here. Because the longer you go without a good hematologic response, the organs are going to continue to worsen, and you get to a point where the patients cannot tolerate the treatment, and then you lose. So with the introduction of daratumumab, the median time to a hematologic response has become very short. The light chains come down to near normal in the first couple of cycles. You can get a very deep response with the daratumumab-based regimens. So then if you are able to get a quick response, then you really don't, and get a deep response, then you don't really need to do an autologous stem cell transplant in those patients. Now, the other advantage is, it doesn't preclude the use of an autologous stem cell transplant later on. So there was a phase in between where people are getting really good response. We would collect and store the stem cells and then continue on therapy, thinking we would be using the transplant as a second line treatment. But you could argue that you don't even need to collect and store the cells anymore because you are not using any therapy that is going to preclude the ability to collect stem cells. And the Andromeda regimen is a time-limited therapy. So you give these patients 2 years of treatment, you stop treatment. Now it may be several years before they relapse, and you can always collect the stem cells at that time and go directly to stem cell transplant without necessarily even doing any treatment, depending upon how fast the disease has relapsed. So for all those reasons, I think the stem cell transplant volumes have gone down dramatically for patients with light chain amyloidosis, all for the right reasons, but it still remains an important tool, I think, as many of these patients who are getting daratumumab-based regimens, when they have a recurrence, I think transplant could be something to be considered, especially if they relapse early after the daratumumab-based therapy.
So even if they get some partial response also, we can proceed for transplant, sir, in this
Absolutely,
like
yes.
myeloma?
I think it's an important thing too. I think, the ability to get to a transplant, get to a response early on, it becomes a little bit of a challenge for the cardiac patients, right? So if let's say they don't get a quick response, they're not getting an organ response, the chances are that they may not be eligible for transplant anyway. But if it is somebody who otherwise is transplant eligible, you give them 2 cycles of therapy, they don't have a PR, you give them 4 cycles of therapy, you still don't have a VGPR. I think that those are the patients whom you should consider taking to transplant if they're eligible from all the other criteria standpoint.
The next question, sir. I think nowadays we have this subcutaneous Daram also. So I think can we substitute with this intravenous to
Certainly,
no,
yeah.
there isn't.
I think they
yes.
absolutely they're totally equivalent, and many of these studies have been done with the sub-Q data.
Okay.
2 things to keep in mind. I think there is probably limited data in people with significant anasarca. Again, a lot of those really advanced heart failure patients were not included in these studies. So whether that will interfere in some way with absorption, we don't know. And the second important thing is to always keep in mind, it may not be as relevant in the Dara-Cybo-D combination, but body weight, right? So most of the dose of 1800 milligrams is optimized for somebody in that 60 to 70 kilogram body weight. So if you're dealing with somebody with a much smaller person, and if you're combining it with medications that also cause neutropenia, whether it be Revlimid in the Dara-BRD or the Cytoxan in the Dara-VCD, something to keep in mind, you might see more of neutropenia.
Thank you, sir. Any other from any? I could not find any questions in the chat box, sir. And if nobody's, I'll ask one more question, sir. Yeah.
So
there is some the patient.
Arun has
yes,
raised this.
Yeah. Okay, Dr. Arun. Yeah.
Oh, no, I had a practical question. I wanted everyone's input on this. This is about using daratumumab. The way we infuse daratumumab, especially in those with stage 3 weak cardiac amyloid, what are the dilutions we are using actually, sir, on a practical endpoint? We know it's all written down in textbooks, how much of data goes into how much of fluid, but with stage 3B cardiac amyloid, what dose adjustments are actually making when you make an infusion for the patients you're treating?
It's still very small volumes that we're going to be, again, it's become kind of a moot point right now because a lot of us have completely switched over to sub-Q, so it's not an issue there at all. It's mostly with the IV infusion. And again, I think, part of the problem is with the infusions, it can become challenging with the rate increase over time if you dilute in a very small volumes. But so especially with the first dose, it may be a little bit difficult to make small dilution or small volume dilutions. But subsequent, once you are kind of over that first dose and the infusion reaction risk is very low, you can certainly start diluting them in or concentrating them more for some of the infusions.
So, Shaji, can I ask one question to you? So, coming back to the same study and use of data in the amyloidosis as such. So, let's say there is a situation where the patients get a hematological response within 2 months, 2 cycles of DARA BCT. And there is one patient who is getting a slow response. Let's say after 6 cycles or 7 cycles, the light chains are going down, but the patient has achieved kind of a partial response. And so these are the two situations. So how do you, decide about the number of cycles in both the situations? Somebody who has achieved a hematological response within 2 months, and somebody who is responding but kind of a slow response.
Right. No, I think it's an important question from a practical standpoint, right? So I think the depth of response has to be taken in the context of what is the baseline organ involvement and whether you see an organ involvement, organ improvement happening. So if we take the first person who has gotten let's say, complete hematologic response in 2 cycles, that patient, we're not going to change anything because even if whether the organs are improving, staying the same or whatever, because you have achieved the maximum you can achieve with that particular therapy. And there isn't anything we can do specifically for the organ other than supportive management. Now, the slow responders, we really have to look at it in the context of where we started and what is happening to the organs. So if it is somebody, let's say, with significant heart involvement, I probably won't wait until 7 cycles. If they don't have a VGPR by cycle 3 or 4, I will think about doing something different, either altering the therapy in terms of adding in different agent or, again, it's challenging because there's not a lot of options, right? But if you have let's say you have 11-14 patient who is on DARA-CyBody, significant baseline heart involvement, 2 cycles, only a partial response, I will seriously think about adding venetoclax or switching to venetoclax-based regimen. Now, if somebody, let's say the same patient just isolated nephrotic syndrome and the light chain slowly going down 7 cycles into the treatment, I won't do anything different. I will just continue with the treatment because there's no urgency in getting an organ response. Now, let's say the first patient with cardiac involvement. Now, he or she only has a VGPR by cycle 4, but actually the NT-proBNP is already showing a cardiac response. Then I wouldn't change anything. I would continue with the same therapy. So you have to think about how fast do you need an organ response? Is an organ response already happening? And what is the depth of hematologic response?
So in the first patient, so how many cycles do you want to give somebody who has achieved a complete hematological response?
Right now, we don't really have much data in terms of a response-adapted therapy. So I think most of us generally just stick with the Andromeda regimen of 6 cycles of everything and then continue with the DARA for the 24 months. So now there are studies ongoing asking important questions. Do we need 24 months? Or can we just get away with 12 months? Or can we use a response-adapted therapy, like treat them to the CR or maximum response and give maybe 3 more cycles of treatment and stop? And the other important question is, do we really need cyclophosphamide here? It's debatable whether the cyclophosphamide is really adding anything. It was part of the regimen because VCD was the control arm. So I think those 2 questions still need to be answered. I think generally, after 1 year of therapy, if somebody is already in a CR, organs are already improving, I often tend to back off on the treatment and see what happens. Because if someone is in a heme CR and the organs are already responding, we have a lot of advance warning to intervene if something should change, because as soon as we see the light chains moving in the wrong direction, we can either restart therapy or start a different therapy. Because you don't really have to wait for the organs to change in order to make those treatment decisions. But I think that's kind of where we are headed. So again, especially if you're in a resource constrained environment and you don't want to be, paying for 24 months of therapy, I think it's very reasonable to give to minimum of 6 cycles of therapy and 3 more cycles after maximum response, and then watch them.
So
So there's
just
one
in-
question. Okay.
uh,
Sorry, sir. One question
sorry,
typed
sir.
somewhere. Okay. I continue.
I just the question which is just similar to that. So so we know melphalan is a very good drug for the amyloidosis, and that's why we consider doing a transplant. So let's say somebody who's a transplant ineligible. Are there any new trials which are combining Boti, melphalan, Dexa, and Dara? Because I was thinking, cyclophosphamide does not have much role. So if you can add melphalan with bortezomib in a patient who is transplant ineligible, whether is there any trial which is going on, or
The Dara BMP regimen, there's been phase 2 studies that have looked at it. There's really no way to compare them. So the question is, if you're using daratumumab, bortezomib, the question is, does alkylator add anything more to it really in terms of getting that rapid response? And I don't know if it is, without a clinical trial, it's hard to say. But at the same time, for somebody who is transplant ineligible, and daratumumab is not an option, then certainly melphalan, bortezomib, and dex combinations have been studied by the Italian group, and it's a very good regimen. And the melphalan and the combination is better than either meldex or using just bortezomib dex. So I think that's certainly something to consider in an older patient population whom we are not thinking of taking to transplant in future and cannot access daratumumab. I think instead of CyBody, AV, bortezomib, MVD or VMD regimen would be reasonable.
makes sense, right? Thank you.
Yeah. There one question in the chat box, sir. I think you have answered that. At what time point, at the time of relapse, either AL amyloid or this serological progression or organ involvement? I think you answered serological progression. I think you can.
Typically, we would like to start at serological progression. Again, it all depends on the context of the patients. So 2 things you have to keep in mind. You never want to get the light chain back up to the same level that the patient had a diagnosis. And every patient has a different threshold, right? So if somebody was at diagnosis, let's say had 200 milligrams per liter of the involved light chain, in that patient, let's say it goes from, let's say 5 to 10, I'm not sure if I would jump into treatment if that patient already had a complete organ response and is doing very well. We would want to wait and see what the trend looks like. In contrast, if somebody had, let's say, 15 milligrams per liter at the time of diagnosis of the involved light chain or 30, then I would be quicker to start therapy if the patient goes from a 5 to 10 or 5 to 15. So you have to also take it in the context of what was the starting, what is the light chain at the time of diagnosis? Is the patient already in a complete organ response? So you actually have more time to watch the patient, and also the trend of the increase in the light chain.
If any patient progresses on DARA maintenance therapy, the serological progression, again, what regimen we can use it, sir? Again, what DARA based, just or DARA can withhold for some time.
Right. I mean, if somebody is relapsing on daratumumab maintenance, and I would use a regimen that does not include daratumumab, or if somebody relapses like very soon, right? You stop the daratumumab and 6 months later they're relapsing, then I would seriously think about using an alkylator, either a alkylator proteasome inhibitor combination, or if somebody doesn't have significant heart involvement, an IMiD based combination.
So we can skip the DARA in that scenario. The
Yes, I mean,
progress
if the clone is refractory to
Okay,
DARA, I don't
okay.
think you are gaining much.
Thank you, sir. I think there's one more question in the chat box. Can we add DARA to VCD if patient has partial response to VCD at 4 cycles? And
No, I think it's a
how-
very reasonable thing, right? I think if
Yeah.
you're thinking about a cost
Yeah.
considerations, because we know that there are some patients who are very sensitive to VCD. So what I would do is base the decision on the degree of organ involvement, right? So if you have somebody with isolated nephrotic syndrome or have like early cardiac involvement, and you have time, right? It's all depends on how much time you have before the patient gets to a point where you cannot pull them back. In those kind of low risk situation, if you start with VCD and you're not getting a good response, complete response for VGPR by 2 cycles, add daratumumab. I think it's a very reasonable way to reduce the cost of care.
Same continuation of questions. How many DARA VCD cycles to be given before we assess the response?
I would assess the response at the end of each cycle in the beginning during the first
Okay.
6 cycles, because you really want to know if the response is fast enough.
Yeah, thank you. Arun, I think Dr. Arun, I think you
Yes, sir.
wanted to raise the hand. Yeah.
I was just surprised with the Andromeda trial design. So, like, strangely, they did not include the stage 3B cardiac amyloid in their trial group, and they were using subcutaneous DARA there. Now we are talking about IV DARA and its safety in stage 3 cardiac B amyloidosis. I was just wanting to, what is your thoughts on the Andromeda trial group investigators? Why did they selectively exclude the stage 3B group, even when they were using subcutaneous DARA in their study, actually?
Right.
So
I think the volume is never a consideration. The sub-Q versus IV is never a big issue with the stage 3B patients. The reason why stage 3B were excluded was because the historical data is a 50% mortality at 1 year for patients with stage 3B or higher. So so that would have really made the clinical trial design a much more difficult one, because again, a lot of the early mortality in a clinical trial setting can make or break the trial, especially if you end up with a significant proportion. I think it was more of a strategic decision. It's a question of where do you think we can demonstrate benefit the earliest, and you can argue either way, right? I mean, the patients with stage 3B are probably the ones who needed it the most, but from a clinical trial, registrational trial standpoint, you want to always try to keep the patient population relatively homogeneous. I think the intent always was that you would study these patients later on once we prove that it's beneficial, which is what the European Myeloma Network has done with their phase 2 trial that has been published looking at DARA combinations in the 3B.
Any other questions from anyone or any comments?
Sir, if there are no more questions, then I would like to thank Dr. Maithili for a wonderful presentation, Dr. Sadashiv sir for his moderating and for participating in the whole thing, and Shaji sir for early in the morning being part of Image and trying to help answer queries by various people. So I thank everyone for helping out on this. So now next we are going to have a quick presentation on the current the data analysis of the Image database, the National Myeloma Registry, before I hand over the stage to Arun for conducting the quiz. So Nirav, can I share my slides, please?
Yes, you can, sir.
So we are going to go about this data analysis presentation in bits and pieces. So because we have only 5 minutes in every journal club for presenting this, so I'll present broadly the demography. So the first aspect is when we keep saying that the myeloma occurs a decade earlier in our people. Now with almost about 5,000 patients in the registry, we have a median age of 66.1 years and a mean age of 65.3 plus minus 12.5, which is no different from what has been reported in the Western database. So when people keep saying, and there are multiple publications from different part of the country wherein they say that the median age is somewhere close to 50 or 55. So this is something which has been refuted by the National Myeloma Registry and with the patients from across country. So it's 66.1, the median age. And also we have somehow a male preponderance. Now this could be primarily because the data is coming from the hospitals, and as we know in India, many of the males, for any disease that we take, the males approach the hospitals for more treatment when compared to the females. So maybe in the same trend, or maybe males are more affected. We are really not sure. We need to get into the details of it. But the male is 64% and females are 36% in the complete database. This is the educational status of the country. Why I have brought up this slide of socioeconomic status is when we keep targeting for various patient group meetings, various patient awareness activities, what we really miss out about is about 40% of the people who are not educated at all. That means less than two second class of standard education. And we almost have 20% more of the people who are below 10th grade. So we have around 50% of the population, 50 to 60% of the population who are below 10th class or the 10th grade. The average, the median income for the family per month is around 10,000 Indian rupees, coming to around, with the current dollar rate going very strong, somewhere close to around $100-$120 per month. That's the cost, that's the monthly family income, not individual income, family income for most of these patients. This is also important because when we keep talking about the various drugs and the monoclonals in particular, so in the absence of any generic forms being available, so we need to understand how much of the monoclonals would be available. And as of now, there are only 2 states which are giving free daratumumab. One is Rajasthan, and there's one more state. There are 2 states which are giving free daratumumab. Otherwise, daratumumab is not available through the state resources as well. This is the CRAB manifestations of the newly diagnosed multiple myeloma. So many of our patients have got extensive bone disease to start off with. That's one thing which stands out, followed by anemia, having a prevalence of around 75% of all the patients who present with features of anemia. Whereas when you look at the hypercalcemia and renal dysfunction, so that's around 50% each. The other manifestations, which we generally talk about in the newly diagnosed multiple myeloma, so infections form around 7% of all the patients. Now, this could be slight amount of, there could be slight amount of underreporting also in the database that we are collecting. So not many people might be entering the patients presenting manifestation as infection, because by the time the patient is referred from a general physician or an internist to that of the hematologist, the infection is generally handled and then referred to the hematologist. So hematologist, when they start recording, the hematologist or the oncologist, they start recording the information. So probably they are not recording infection at that time. Another important aspect that we found is around 25% of the patients of our in our cohort have more than 5% of the weight loss at presentation. So that's something which is something different that we found. Now, coming to the prognostic staging at presentation. So if we look at ISS staging, so we have stage 1, 20%, stage 2, 35%, and stage 3, 45%. And if we look at RISS, we have stage 3, 24%, and stage 2, 76%. We are coming up with a analysis of institute versus out of institute cytogenetic and assessments. And what we have found is all those places where there is a within institute availability of cytogenetic evaluation, the cytogenetic positivity is almost around 90 to 95%, whereas where people outsource it to other places, either because of pre-analytic errors, because of lack of plasma enrichment, or lack of standardization, the positivity is somewhere between 12 to 18%. So there's a huge difference, particularly from PGI and TMC, where they have in situ cytogenetic evaluation versus other parts of the country where we all outsource. There's a huge difference. Therefore, RISS staging in our country, we are not really sure how much should we pay heed to it. Is it really that the stage 3 people are a smaller cohort? Now, coming to the relation of symptom onset to that of diagnosis. So here you find that you find on either side of 0. So you find that many of the people, there's a huge delay. If I just look at the positive side, the median delay is around 250 days from the first symptom onset to that getting diagnosed. When you see the negative side connotates that most of the times, once the patient has got diagnosed, because we are entering the symptom onset from the time they have met a hematologist or an oncologist. So many a time this also shows in India that almost around 5 to 6 months, the internist or the general physicians, they keep managing the patients before the patient comes to a hematologist or an oncologist for management. Now, this is the overall survival of the complete cohort. So the 1 year survival in these patients is close to around 80%, which is not bad at all. And then if we look at the 5 year survival, it's close to somewhere around 76%, which is also quite good. So this is the survival across institutes, not from one institute. And this is interinstitutional variation. Now, again, there are some caveats in presenting this information. We are in the process of doing a source data analysis or the source data verification. So not many institutes are capturing the death patients or the patients who have actually been sent back home for hospice care and are not entering the data. So there might be some reason of 5 to 6% or maybe 10% higher reporting of the overall survival. But that would be constant across institutes. So this is the interinstitutional survival. In the next meeting, we will be presenting about the therapy regimens, which are used commonly in first line, second line, third line, the response rates to these individual regimens, overall responses. And also we have just completed a screening of 10,000 individuals in 58 villages from tribal districts. We'll present that information. And also we are at the final stages of analysis of CAR-T and allogenic transplants in our country in myeloma. So we'll be presenting these in the next Journal Club, which is going to happen on the 4th Thursday of April. So I think it's 25th or 26th of April, and wherein we are going to discuss something on Waldenstrom's or amyloid again. But at the same time, we are going to have a small set of data presentation of Indian data from our country. So with this, I stop sharing my slides and I'll hand it over back to Arun for taking on for the quiz.
Uday, can I ask you a quick question?
Yes, sir, please, sir.
So what was the total number of patients in the registry?
Sir, it's 5,022.
5,022. So yeah, I wonder if, and it's a question for everyone, how many of those ISS, the stage 3 ISS, right? So these are all the beta 2 microglobulin driven classification. And one thing I have seen often in patients whom I see from India is almost everybody has a high beta 2 microglobulin. And I wonder if there's a difference in the normal range between population, and we are ending up misclassifying some people as stage 3 purely based on beta 2M. And it's such a non-specific thing. So many things can drive beta 2M up as well.
So, sir, what we have done is now, as part of the screening, for what we are doing for the myeloma screening or the plasma cell dysplasia screen, we have actually tabulated the complete beta 2 microglobulins of all these individuals. Of those
Normal
who do not
individuals.
have something on the SPP as well.
Got
So
it.
we have
Okay.
that information with us, which I will send it across to you, sir,
Okay.
so that you can have a look at it. So we have collected this information on your ID only around 2 years back. You told us that like when you came for the Bangalore meeting, so at that time, it was discussed that we should tabulate the beta 2 microglobulins from the country. So what we have done is we have taken that information. We also have taken the RFPs of all those people who have a raised beta 2 microglobulin, because that is one of the primary reason for having an abnormal one. Thing, and we have the complete proteins, all the different proteins for normal individuals who do not have a M spike. We have tabulated that, sir, and we have put that together.
Good.
So
Great.
this 11,000 patients that we have the data till now will give us some fair idea about the trends of beta 2 microglobulin.
Perfect. Thank you.
Yes, sir. Pankaj, sir, any comments from your side, sir?
Obviously we need to little bit edit the data, because from the different hospitals, when we are collecting the information, obviously it is the average of that. And as you already said, one is about the cytogenetics, the other is the infection part of it, which seems to, I mean, how do we define the infection? So that part is also little bit we need to work on that. And the third thing is about the weight loss. I don't know. We don't consider B symptoms in myeloma. Generally we consider B symptoms only in lymphoma only. But if we find this weight loss as kind of a significant, and whether that has any relationship with the outcome of patients with myeloma. So that would be kind of a very simple clinical parameter which can tell us about the outcome of myeloma patients. I don't know. I'm just was intrigued by this observation of weight loss, which we need to look at this.
Sir, in fact, this was actually given as a thesis topic at AHRR to one of my students, and then we started recording that too many patients have got a weight loss in myeloma, and then we included it as part of the registry, and we told everybody to keep capturing the weight records at every visit. And then we found that many of these people have actually committed. When we start querying or asking them about weight loss, that quite a number of people have it. But again, pre-hospital records in India, the biggest problem is we do not have a clear documented evidence for what is the when at the time of symptom onset or that part of it. So there is a small caveat, but within the first 2 to 3 months also, we have the trends of the weight now with us available, sir, and it clearly shows that the weight starts improving by third cycle or fourth cycle, and patient says that हम वापस उस stage पे आ गए हैं जहाँ पे हमारा पहले था, sort of thing. So yes, this needs to be carefully looked into. But yes, as you said, sir, like we might actually come up with some new finding altogether.
But anyway, good work, good analysis, the basic analysis. So I'm happy that at least we are able to show something with this.
No, this is very important data, especially the whole age thing too. I mean, you just keep saying it's younger patients, but here we have like systematically collected data showing it isn't the case. So.
Thank you, sir. Over to Arun, please.
Nirav, could you please share my screen, please? Thank you. You can move to the next 2 slides. So good evening all. So as every time we meet up, we have this quest where we do 5 questions in a jiffy, and we tend to discuss what has been discussed in the journal club with some trivia questions. So we move to the first question. It's fastest fingers first. You have 30 seconds to answer the question. So this question is based on the Andromeda trial, which was actually a prelude to the trial which was just discussed. It's about which of the following was not an exclusion criteria in the trial which used the study protocol, which is shown here. You can use the clues in the diagram, and you have to tell me which was not an exclusion criteria in the trial. So whether it was a previous or recurrent diagnosis of myeloma, a planned stem cell transplant during the first 6 cycles of protocol, was it grade 1 painful peripheral neuropathy, or a systolic blood pressure of less than 100. We move to the next question, and because the discussion was on cardiac stage 3B, this is a useful diagnostic modality when you assess organ dysfunction, especially cardiac dysfunction in amyloid. This is how a tracing looks like when you do a particular test for screening cardiac amyloid. And you need to tell me which of the following tests is being depicted here. It's a beautiful pathognomic chart which is being shown here. So you have to tell me whether it is a spectral tracking echo, or a pyrophosphate scan, or an MRI, or a SPECT tracing, which is shown here. Most often we read the reports and not see the diagrams ourselves. So this is how it looks like. The next 3 questions are in fact based on what Dr. Maithili discussed in detail and Dr. Shaji alluded to. So this is about the overall survival results, which was discussed in the trial. When you look at the role of DARA in stage 3B AL amyloid. So you have to identify the incorrect statement here. There are 4 statements given. So all these points were discussed in detail by the speaker here and dissected out by the moderator as well. So 2 more questions on the trial. This is with respect to the response rates with respect to DARA in the same subgroup of cardiac stage 3B AL amyloid. Whether none of the patients achieved a cardiac CR in any of the treatment arms, or did we have more cardiac VGPR in the DARA group? The 12-month overall survival data is given here. Is that correct? Or you found DARA was useful across all NT-proBNP levels, or was there a ceiling of NT-proBNP beyond which DARA actually did not make any difference? And if you were carefully listening to the subset and the subgroup analysis and the forest plot which was shown towards the end, with respect to the study, at least in what subgroup were DARA useful, is clearly evident. So you have to tell me whether DARA was useful in all subsets except for one of these subsets. The DARA was not found to be that useful. But we must understand that when we apply these to subset and subgroup analysis, the study is usually powered for not these endpoints. Thank you. As the results are being compiled and the winner is being announced, let me discuss the answers with you. We move to the first question. That was about the Andromeda trial, and you can see the Andromeda galaxy down here, and the whole protocol is shown here. But in the Andromeda, the cutoff was a systolic blood pressure of less than 90 and not 100. So you have to critically analyze some of the inclusion-exclusion criteria before you apply it onto your patient who you are treating. The next question. The next question I told you was about how 2D echo and modalities like speckle tracking echocardiography, that is actually an assessment of the longitudinal strain in the cardiac chamber. This is a 4-chamber view of the heart, and you can see there is a classical cherry on top or lollipop appearance, where there is an apico-basal gradient in the strain pattern on echo. Although we keep talking about the telltale signs of low voltage complexes on ECGs and speckle pattern on echo, this is something more specific. And most of the patients cannot be biopsied because of performance status and other complications. So you have to sometimes rely on these modalities to pick up cardiac amyloid. And the other 3 modalities are not that as specific for AL amyloid, especially with cardiac involvement. The last 3 questions I told you were on the trial which was discussed. So this was beautifully brought about by the speaker, that in the regression analysis, none of these actually could predict overall survival in this cohort of patients. Neither the DFLC or the pro-BNP level could predict overall survival. What actually made a difference, whether the patient was alive at the end of follow-up, was whether the patient received DARA or not. None of these parameters, pre-baseline parameters, actually made a difference to the overall survival. The next question. That was about whether DARA actually helped all subgroups and what was the kind of cardiac responses with DARA which you get. So what is important to know that none of the patients actually achieve a cardiac CR even in the DARA arm. But what we must understand that when we saw the subset analysis, DARA does help across all subgroups based on the BNP levels, and it, even up to the tune of pro-BNP level of almost 25,000. But beyond that, there was a ceiling. And beyond 25,000, we actually did not see any substantial benefit of adding DARA. That definitely remains an unmet need in this subgroup of AL amyloid. The last question was about the subgroup analysis, and this actually forest plot was actually shown by the speaker as well. And you see that when there is a proteinuria exceeding 5 grams, most of the drug is actually lost by the body and not retained. So DARA doesn't actually come to help this subset of patients when the proteinuria is massive to the tune of 5 grams per 24 hours. But in other subsets, when the NT-proBNP is more than 25, or the DFLC is more than 180, or when you have a GFR which is more than 30, DARA actually made a difference to that patient. So this is some subset of patients where you must be careful when using DARA VCD in AL amyloid. Maybe this subset where the DARA may not peculiarly help. Thank you all for a patient listening. Nirav, do we have the winner?
Sir, Dr. Ramesh B from Meenakshi Mission Hospital and Research Center, Madurai.
Oh, Dr. Ramesh, congratulations. Please do tell us your mail ID. We'll be sending you the voucher and the certificate, and keep participating and keep enriching the forum with your presence in the subsequent sessions. And with that, I hand over the proceedings to Dr. Uday for the concluding remarks.
Thank you, Arun. Thanks for a wonderful quiz as usual. So the next meeting, we are going to have it on 25th of April. So that's the 4th Thursday. So I would request every one of you to join back 5:30 evening, 25th of April for the next Journal Club. Thank you. Thanks a lot. Jai Hind.
Thank you very much, Amanda.
Thank you.